Good afternoon, ladies and gentlemen, and welcome to the last session. We have two different areas to go through now. Very late in the day, the last keynote is from dede dunevant, from Physicians for Human Rights. Physicians for Human Rights, I think we all know, it's a USA-based organization. There are different bits of PHR elsewhere in the world. But many of you have seen the extraordinary documents which they have. They're all available online. They're investigations into human rights abuses in different parts of the world, which are academically rigorous and at the same time incredibly readable, which is a really important element in getting people to engage with human rights, which is not always the easiest issue for people to engage with. And of course, it was Dede's colleagues and Dede who were involved in setting up the process that led to the Istanbul Protocol, of which I think everybody is extremely proud, not least, of course, the Turkish Medical Association and the Turkish Human Rights Foundation, who were so involved in that. And Dede is going to talk to us today about how doctors fit in as the champions of people seeking asylum. Dede. Thank you very much, Vivian. Good afternoon. First, I'd like to thank...
Thank you. Thank you, Vivian. Good afternoon. First, I'd like to thank the Turkish Medical Association, the World Medical Association, and the Istanbul Medical Chamber for inviting me to speak today. Physicians for Human Rights has been a proud partner with these organizations for a long time, so we're very glad to be here today. I'd like to begin by speaking about one of the root causes of the massive displacements of people that we're seeing today. It's a root cause that I hope will be close to the hearts of those of you in the room today. It's the targeting of healthcare workers and the deliberate destruction of the healthcare system in Syria. At Physicians for Human Rights, we're documenting how Syrian and now Russian forces target health facilities and medical personnel, multiplying the horrific effects of this conflict. At a time when people need access to medical care the most, hospitals are being destroyed with bombs, and doctors are being killed with missiles or detained and tortured to death. The numbers are astonishing. Between March 2011, when the conflict began, and the end of 2015, we've documented the deaths of 705 medical personnel, your colleagues, and 346 attacks on medical facilities. 2015 was the worst year yet, with more than 100 attacks on medical facilities. And while ISIS grabs the headlines with its exhibitionist violence, it's the Syrian government that has committed 90% of these attacks, systematically violating international laws aimed at protecting civilians. As has been mentioned here over the last couple of days, it's ironic that Bashar al-Assad trained as a doctor himself. And as a colleague of mine likes to say, it does rather seem that he missed the ethics classes. Medical workers in Syria are specifically targeted, tortured, disappeared, or killed because they bear witness to human rights abuses. They're often perceived as the enemy for treating people on both sides of the conflict. The absurdity of the situation is particularly stunning, as our colleague from MSF has pointed out. Rather than clearly marking facilities with the Red Crescent and giving their coordinates to warring parties, which is the standard practice in a war zone, Syrian doctors go out of their way to hide their identities and their facilities. It's important to note that the worst humanitarian crises in the world today began as human rights crises, Syria being the worst among these. But as refugees leave Syria to seek safe haven, who will provide them with medical care? Host countries are overwhelmed, yet Syrian doctors are not permitted to practice medicine outside of their home country. Last month, Physicians for Human Rights called for emergency measures to allow Syrian medical workers to treat refugee populations and contribute to one solution to the crisis. Leaders must invest in new medical centers and support existing ones where Syrian medics can serve their own people. They must also invest in the host country's medical education programs and in special grants and scholarships so that Syrian students who were forced to cut their studies short before graduation can complete their health qualifications elsewhere. If we're going to rebuild the Syrian medical system someday, we must start now by supporting Syrian doctors and medical students. So let's talk about the people who are fleeing this conflict. People in need of medical care, and people who must be able to claim those rights which are typically defined as the social determinants of health. Let's start with some basics. War is hell. It's hell on the combatants, but war is also hell on civilians. But maybe it's more like the different levels of purgatory in Dante's Divine Comedy. The lowest level of purgatory is when civilians are deliberately targeted, whether by bombs, chemical weapons, besieging of cities, recruitment of child soldiers, or sexual enslavement. The next level of purgatory is when the parties to the conflict act with utter disregard to the consequences of their actions, and civilians are caught in the crossfire or buried under the ashes of a scorched earth policy. Another level of purgatory is when security forces treat all civilians or some specific groups of civilians as suspect because of perceived identification with or support of another party to the conflict, resulting in internment, detention, enforced disappearances, torture and ill treatment, or extrajudicial executions. And the final level of purgatory is the stresses associated with living in a conflict zone and diving under a table every time you hear the whine of the engine of a jet or a plane that you've come to recognize as delivering death. I think this latter circle of purgatory has been largely under-acknowledged. Two researchers at Johns Hopkins University attempted to do a survey of deaths in Iraq after the 2003 invasion by the US-led coalition. They found a significant increase in mortality rates that they argued correlated with the invasion, but were not a direct result of being caught up in the hostilities. Their study was attacked, and it'll be important to refine their methodology, but there's no question that stress is bad for one's health, and living in a war zone is certainly stressful. So what role do doctors have to play? At Physicians for Human Rights, it's our profound desire to have all doctors recommend the power that they have as doctors to promote human rights. It's simple. Human rights is about the inherent dignity and equality of every human being. In the context of addressing people displaced by conflict, this means that doctors have a powerful role to play in recognizing, treating, and advocating for the treatment of the obvious and the hidden wounds of conflict that are both physical and psychological. In addressing abusive practices by states that put asylum seekers in conditions that replicate their trauma, including detention, harsh interrogations, splitting up of families, and denial of care. They have a role to play in supporting rehabilitation and reparations for the victims of these conflicts, and in supporting the asylum process by doing forensic evaluations of asylum seekers claiming specific forms of persecution. And of course, a forensic medical evaluation can do more than support an asylum claim. It can help your patient seek justice. If you're trained in the principles of the Istanbul Protocol, use it. If you aren't, get trained. It's a remarkable tool that helps you not only heal your patient, but contribute to their ability to gain justice for what they have suffered. And here I'd like to paraphrase one of my favorite physicians, Dr. Denis Mukwege. He is the Congolese obstetrician who won the Sakharov Prize in 2014. Faced with a crisis of rape as a weapon of war in his country, he said, "I saw that I could no longer simply repair my patients' bodies. I had to become their advocate." But your role can go beyond these more obvious medical and advocacy roles for doctors. Everyone in this room knows about the social determinants of health. And allow me this brief aside just to say what the medical and public health fields define as the social determinants of health, we think of as basic human rights, including the right to education, the right to water, the right to adequate housing, the right to be free from violence, the right to privacy. I could go on, but to reiterate the fundamental point about human rights, it is what people need to live in dignity. Doctors working with people displaced by conflict have a particularly powerful voice to exercise in promoting the obligations of governments to fulfill these rights that are the social determinants of health. We're meeting today in Turkey, a country now hosting nearly 3 million Syrian refugees. Many of their children have been without access to education since the conflict began in 2011. Yes, as doctors, you need to address the need to receive pediatric care, get appropriate vaccinations, address any trauma-related issues, but don't stop there. Be their advocates for education. And I'm focusing on education because as correlations go, once you address the basics of food, clothing, and shelter, nothing correlates more strongly with health and other measurements of well-being than education. So let me go back to an earlier point I made. At Physicians for Human Rights, we want all of you to engage in the movement to promote the dignity and equality of every human being. As doctors, most of you enjoy a privileged position in your societies, and I urge you to use that position. And rest assured, when you speak out to defend the rights of those who are excluded or demonized, if you yourself become a target, we will rally around you and organize the many groups represented in this room to stand with you. With privilege comes great responsibility. And I'm here today to ask you to exercise that privilege. Millions of vulnerable people are counting on you to do so. Thank you.
Thank you very much, Dede. I'm sure that there are going to be questions. I think that was a great tour de force in a very short time. And I particularly liked the linking back into our opening plenary about social determinants and this issue of following people throughout their life course and giving them the ability and opportunity to thrive, to do well, to be well. And that's a tremendous part of actually the whole agenda that we've had for the last 2 days. People have talked exactly about respect and opportunities for people to be treated well. We have some time for questions. I'm going to be very tough because I know everybody needs to get away to get trains and planes. So anyone who wants to speak, absolutely fine, but can we make sure that they're questions at this point rather than long statements? Hands up for anyone who wants to add to this. The microphone's just coming. Yeah.
I think the major issue here is lack of information on the part of the people who disagree with us. I think we all agree on the essential elements here. We understand these social factors, we understand the rules. Communication. How the hell can we cross this border?
It's an excellent question, and I don't think one that anyone has a perfect answer to. But I do think that we have found that by acting in coordination rather than individually, we always have a much greater effect than if each medical association, each NGO operates on their own. If we can come together and jointly determine what's our messaging, who are our targets, who are the actual people who can make change, and be coordinated in that effort, we have a much greater opportunity for success. And we've seen that with individual cases here in Turkey, where a number of medical associations represented in the room today came together to advocate on behalf of Turkish physicians, and it was much more powerful than Physicians for Human Rights saying X and the BMA saying Y. And so I do think coordinated messaging is important and not something that the NGO community has really succeeded in yet as regards this crisis.
If I can just add to that, I mean, one of the things that we need to learn from is the power of social media. And it strikes me that when you see terrible things like the bombing of an MSF hospital, the thing that means that it can't be hidden is the fact that people got out their smartphones and took pictures of what was happening and broadcast them. And it doesn't then just become friendly fire incident or something of that sort, it becomes, quite rightly, a human rights outrage, because we can all see it. And we've got to get smart at using that system, because there's an awful lot of other people who are much smarter than the doctors are at using it for ends, and we would want to use it for good ends, so that's a good thing to do. More questions? Everybody's quiet. I mean, just one thing to say. One of the things that the WMA is doing is we're a partner with the International Committee of the Red Cross in their Healthcare in Danger project, which is looking at attacks on healthcare workers, healthcare institutions, and the patients in them, and trying to record that and trying to get it stopped. And they've got what they call a community of concern now, which they're changing to a community of action. And one of the things that they've talked about is to get more data on attacks, they want to use media, and they want to use national media. So if a newspaper in a country is saying there was this attack, is that valid? I mean, I would just be interested, do you think that that would actually help us to gather more data? The World Health Organization is saying maybe it's a valid opportunity.
I do think it's a good opportunity, and in fact, the team at Physicians for Human Rights that documents attacks on healthcare, they rely regularly on social media and on information. Now, we corroborate each of those reports. We don't just use any one report, and that's, by the way, why our numbers are so low. Many more health facilities have been attacked, many more medical professionals have died. Those are just the numbers that we can really solidly corroborate and are comfortable submitting to the Security Council. And those numbers are submitted and presented to the UN Security Council every month, and one hopes that someday they'll actually pay attention to them. But I think that is a new means of corroborating different attacks. If you have it from a number of different places, that does help.
Until someone else puts up their hand for another question, I have one more. You mentioned this issue of getting Syrian doctors recognized so that they can help out in these enormous camps and other facilities in which there are so many Syrian people. The issue there is very often about registration. Have you thought of working with IAMRA, which is the organization that regulates medical regulators? So it's the organization, and I can never remember who in Turkey is the regulator. But for example, Xavier, unfortunately, is not well, so he's gone. He's a member of IAMRA from the French order that he represents is. I think Andre represents the Belgian order, and there's a few others. And certainly Margaret, who was here earlier, also represents Uganda. What more?
May I just report on an initiative that we have started recently, because there has been no move by the agencies who are in charge of that so far. Although the question of cross-border provision of services in the context of emergencies, and we're not only talking about war, we're also talking about natural disasters. And by the way, in the context of sports events, where we have a lot of cross-border provision of services, we have started an initiative to find regulations and ways on how to bring these interests and these questions together, addressing the international organizations. And we would invite, of course, all those humanitarian organizations and human rights organizations who have an interest to join us with that. Because we believe, as you said, that there is a need, that something has to be done. But if we wait for the regulatory bodies, well, you rather may believe in Santa Claus.
Yeah, and to be clear, that proposal is not made lightly and as though we believe that's easy. We understand that each country, of course, has its own system for qualifying physicians and for licensing, but we do think that there must be some opportunities for emergency measures that allow for temporary qualifications to to serve only in the camps, and then that could be handled locally, and that frankly doesn't require a UN Security Council resolution. It's a thing that we can do to ease the suffering of this population. And the other major component that you all will understand is the longer these physicians go without practicing, the more their skills deteriorate. So imagine being a surgeon who hasn't picked up a scalpel in 5 years and what that does to your skill set. And so it's not only a benefit to the refugee population, but it's maintaining the skills of the Syrian medical community.
Yeah. I mean, it's interesting, after the second Iraq War, the UK, we set up a system so that as soon as a refugee came to the UK from anywhere in the world who was medically qualified, we were told they became an honorary member of the association. We gave them journals, we gave them access to English language training, particularly linked to medical English. Because as we all know, you can learn a language but not be able to take a medical history in that language. It's a very different skill to talking to people outside healthcare. And then supported them until they got their permission to stay and were able to apply to the General Medical Council and to get onto the register. And of course what it meant was they never got completely separated from medical practice because they spent a lot of time talking to practitioners and colleagues. And it's now self-perpetuating, that it's the group who came in first and who are in practice who are helping the new arrivals, which is tremendous. And the nurses do the same. And the teaching unions are trying to do the same as well, with some more difficulty for various reasons. But does that happen in any other country? That equivalent? Are there things that we can learn from that?
We have something along those lines.
So yes, in Sweden. So he's just bringing a microphone. Yeah, yeah.
We have a mentorship in Sweden. We have a mentorship system where we try to dock them up with someone who is already out there. Some retired doctors, some people who are sort of secure in their professional role. And we also have systems for identifying those who need some extra training. The major problem we are facing is when there is competition with the ordinary medical school students, and then it becomes sharp. We have a lack of opportunities for hospital-based training. Shall my son have that, or this refugee? I mean, that's where things become complicated. But we're working on it.
Thank you. I mean, at least that gives us something that we could do. I'm going to draw a close to this session now so that we can go very, very briefly, if you can. Have we got a microphone? This gentleman in about the 6th row. Microphone on its way. And then we'll go straight on to the communique so that you can get out of here promptly.
Doktor Ergün Demir, Suriyeli Göçmen Polikliniğinde çalışıyorum. Türkiye'nin ilgili bu konuda yasa çıktı, yabancıların çalışmasıyla ilgili. Ancak hükümet gerek göçmenler konusu, onlar göçmenler demiyor da sığınmacı, evet, statü bakımından nasıl çalışacakları konusunda herhangi bir pratik adım atılmadı. Şimdi arkadaşımız dedi ki bunlar kamplarda, Türkiye'de %10'u kamplarda kalıyor, %90'ı dışarıda zaten yaşam alanlarında kalıyor. Bu açıda ilk öngörüleri üreme sağlığı merkezlerinde, göçmen polikliniklerinde bir istihdam yaratmak, ama bu konuda ne meslek örgütleriyle ne de bu konuda çalışma yapanlarla hükümetin bir teması veya herhangi bir öngörüsü veya talebi olmamıştır.
Yeah, I mean, we recognize this is very early days in this, but it is an opportunity to look and to say what are the opportunities to help these people to stay in practice, but also to help their own populations. And it will vary around the world in different places at different times. But it shouldn't be something that's beyond our ability to create a system that could be helpful to some people and to deal with a problem that also came up this morning of in some places there just aren't enough doctors and nurses to help And that's probably the case in, say, Jordan, with the big camps there. Thank you very much. Thank you very much, Dede.